Hi everyone, welcome to Dr. Deepa's Learning Launch. I am Dr. Deepa and I'm here to discuss a new topic in the clinical pathology session, which is stool for occult blood testing or fecal occult blood testing. This test, it is very important that the quality aspects are taken care of in adequacy so that the test results are actually comparable to the clinical scenario because of high false positives and high false negatives that can happen if the patient is not well prepared. So without much ado, let's go ahead with the discussion today. So I'll just move ahead with my slides. So basically, today I will be discussing the entire stool for occult blood. So I will be teaching you the entire investigations that are required for GI cancer detection based on the stool for occult blood detection. So this will include Goag-Blaze test, the immunohistochemical testing, the dietary restrictions that need to be taken care of to avoid the interferences, the clinical utility of the fetal occult blood testing, and also the implications in newborn and elderly, and the newer technology that are available for stool for occult blood testing. So let's move on. So basically, what is occult? In English, the word occult means hidden or something that you cannot detect with naked eye. So this is the blood or bleeding in the GIT that is not detected by the naked eye and requires a chemical or an immunological test for us to detect the occult blood. So it is clinically important because occult bleeding is often the first warning sign of anything as serious as a GI malignancy as well, but it can also originate from other benign conditions like the peptic ulcers, inflammatory bowel diseases, polyps, hemorrhoids, fissures, and angiodysplasia. However, since it is associated with a malignant status as well, it is very important that, especially in the elderly, the stool for occult blood testing is recommended at least once in 6 months for any regular person. So collecting samples is also very important. So samples has to be collected thrice for a diagnostic accuracy for stool for occult blood. So 3 different days you have to test it before calling it negative. So and another thing very important is to avoid contamination with urine or water, and it has to be only the stool sample that is collected with precaution. So you have to apply another important thing is during the testing of the guac test, a thin layer has to be put on both the control and the test areas, and never rehydrate those slides. Never rehydrate the occult blood test cards because dehydration will cause a false result. And another thing, always develop the test within a couple of days. You should not keep it holding for a long time because the hemoglobin can degrade. So there's not much transportation that is allowed. So as early as possible, within a day, you will have to look at the sample and detect it. Long transportations are not allowed. So there are several kinds of occult blood testing. So the traditional method is the GOC-based fecal occult blood testing, which detects the pseudoperoxidase activity of the heme moiety. And we also have immunochemical or FIT testings that detect human hemoglobin specifically. The hemoporphyrin tests that detects porphyrias are useful in the upper GI kind of a bleed. The fecal DNA testing is the latest technology that is available right now. So which this basically looks at the DNA mutations that are shared by the cancer cells. So in newborn, there is another testing called the AP test, which is a newborn swallowed blood test. So this basically distinguishes between the maternal blood swallowed and the fetal blood swallowed. So all of these tests are something we will be discussing today. So this, as you most of you must have seen this in your laboratory, which is a hemospot, which is a GOG-based fecal occult blood testing that depends on the pseudoperoxidase activity of the hemoglobin. So when the hemoglobin reacts with hydrogen peroxide in the test reagent, it oxidizes the chromogen, producing a traditional blue color. Some of the kits also have a green color that depends on the kit insert. Uh, Traditionally, benzidine was used, which was more sensitive, but is now restricted to usage in the laboratory because of a carcinogenic risk. Orthotolidine and dianisodine are the alternatives that are usually used in the latest kits now. And the test is not specific, however, for a human hemoglobin. So if there is any meat ingestion which has an animal hemoglobin, then this test would come out to be positive even with animal hemoglobin. That is a restriction for the test. If you look at the sensitivity and the normal blood loss in a human being, in normal physiology itself, there is some amount of blood loss that occurs, which is not devastating for the patient. So as you know, our GIT constantly sheds the mucosa. So there is some amount of hemoglobin that also comes out into the stool along with it, which is considered normal. So usually, the GI blood loss is in the tune of 0.5 to 1.5 milligrams per day, which is acceptable and it is normal. But the fecal GOG, occult blood testing detects positivity only between 5 to 10 milliliters of blood per day. So look at the difference. There is 0.5 to 1.5 ml per day, which is normal. And the fecal occult blood testing by GOAC method tests between 5 to 10 ml per day. So there's a gap between 1.5 to 5, which is not detected by this GOAC testing. So very early cancers in which you have something between like 2 ml to 5 ml of blood loss that is happening, that goes under the carpet, that is not detected by the GOAC method of fecal occult blood testing. So this amount of bleed, which is 5 to 10 ml per day, is equivalent to 5 to 10 milligrams of hemoglobin per gram of stool. So that is the cutoff at which the GOAC testing of fecal occult blood tests, assuming that the stool weight is about 150 grams per day. So you have to remember that smaller lesions go missed. False positives is the major drawback of fecal GOAC testing. So the major drawback is that animal meat also contains, as I said, it's not specific for human hemoglobin. So animal meat contains hemoglobin and myoglobin. That will also give a pseudoperoxidase activity and gives a false positive GOAC test, which means it is not the patient who is bleeding out, it is the meat that is taken in, which comes out as a positive in the GOAC testing. Other things also which have a peroxidase activity will give a false positivity. For example, vegetables with peroxidase activity like horseradish, turnips, broccoli, radish, cabbage, fruits like bananas, black grapes, pears, and plums. So these are the ones that can give you a false positive with GOAC test because of an inbuilt peroxidase activity in any of these vegetables, fruits, and red meat. Another important thing is usage of usage of an NSAID or aspirin, which would increase the shedding of the mucosa, can also produce a false positive, and that should not be taken as colorectal cancer screening need not be done for those patients. So it's very important that you have the correct history, that whether they have taken an SID or an aspirin in the prior 2 days or 3 days. So these are all things that can give you a false positivity. Another important thing is in case there is an overzealous digital rectal exam that is being done by the clinician, even in those cases when there is an uncooperative patient, especially, there can be some aberrations to the rectum or the lower GIT because of overzealous digital rectal examination that also can cause a slight amount of bleed, which can lead to occult blood testing coming out as positive. So bleeding gums onwards to any area of the GIT can produce a false positive. GI irritants like NSAIDs, can cause a positive. Any of the peroxidase containing vegetables or fruits can cause a false positive. Eating red meat also can cause false positivity. The next, coming to the false negativity. Vitamin C, which is a which is a strong reducing agent, inhibits the oxidation reaction of the pseudoperoxidase. So this gives a false negative result. So when the blood is present, sometimes vitamin C is taken in, especially these days, people are taking a lot of multivitamins, which contains a significant amount of vitamin C. So even if the patient is bleeding out and the GOC is supposed to come out positive, if he has taken a vitamin C, that will inhibit this reaction because that is a strong reducing agent, and it reduces the oxidation property of the pseudoperoxidase of heme, and that is how it will give you a false negative result. So that has to be kept in mind. The second thing that has to be kept in mind is the stool consistency. If it is a completely dry dehydrated stool also, the reactivity can be very slow, and that can also lead to a false negative result. So that is the major drawback of the GOAC fecal occult blood testing. And like I already told you, testing too early also is something that can give you a false negative. So just as I said, there are a lot of false positives and false negatives. So what is primarily very much important when you're telling a patient to get a GOAC test done? The very important thing that you have to keep in mind is to get the patient prepared very well before the testing. So it is not enough if you take 3 samples in 3 consecutive days. It is important that the patient complies with the requirement of testing. The requirement of testing includes one, you should ask the patient to avoid all the peroxidase producing foods to be taken in. You have to ask him or her to avoid meat. You have to ask him or her to avoid all the fruits and vegetables that I told you just earlier, and also avoid usage of aspirin and NSAID, especially in elderly. You have cardiac patients who are put on aspirin and blood thinning agents. So these have to be avoided at least 72 hours prior to testing. Otherwise, there's no use. It will give you a false positive, and you will be unwantedly putting the patient into unwanted testing, including colonoscopy. So these either produce a false positive or false negative results, or you have to ask him not to have multivitamins. You have to ask him not to have aspirin, not to have NSAIDs at least 72 hours prior. No non-vegetarian food, none of the peroxidase producing vegetables or fruits to be taken 72 hours prior to testing. Once you prepare the patient adequately like this, then you're good to go with the testing because you can rely on the results now and there's no false positivity or false negativity chances. Then let's move on to a more specific test because there's so many restrictions now. You have so many vegetables to avoid, you have so much of food to avoid, you have so many medications to avoid, so much of false positivity and negativity. A better, more specific test is the immunohistochemical testing. So the fecal immunochemical testing is recommended as a screening tool, and this is specific for a human globulin in the sense it doesn't react with the oral meat that is consumed by the patient. So this makes it far more accurate than the GWAC testing, but there is one negative here also. The FIT or the fecal immunochemical testing does not detect the upper GI bleed because the human globin gets digested in the upper GI bleed. So basically, that is one restriction. That in the sense, if it is a melena and it's an upper GI bleed, then it won't get detected in the immunochemical reaction. There is another test that can be done for this, which is the heme porphyrin assay. The heme porphyrin assay measures both heme and its breakdown products. So that is why you can measure both the upper and lower GI bleed based on the heme porphyrin test. So this is better than the fecal immunochemical testing. So, what is the utility in colorectal cancers? The colorectal cancer is, as you know, one of the leading cancer-related deaths in the community. So, fecal occult blood testing is a simple, inexpensive screening method, and its sensitivity to detect early cancers is limited with blood testing, but with fecal immunochemical testing, it improved the chances of detection has improved greatly because of less false negativity and less false positivity. But both of these tests, if it turns out to be positive, then it has to be followed up by colonoscopy. Another methodology that is available is the fecal DNA testing that looks into the mutation of the KRAS, APC, and TP53 and microsatellite instability that are common in the colorectal cancers. The DNA is stable in the stool. Therefore, it is sensitive for molecular detection and it is more accurate than the GOC or fecal immunochemical testing and currently available, but it is more costly. Over time, it will become a standard tool for sure. The another test that I mentioned in the beginning was the app test, which is the newborn swallowed blood test. So a newborn may pass a bloody stool immediately after birth, but it can be either due to swallowing of the maternal blood or a fetal blood bleeding. So either during delivery or either during delivery passage through the canal where when he swallows up the blood, or if the child has been breastfed through a cracked nipple, also it can cause positivity. The app test basically helps in determining the source of the blood. The fetal hemoglobin stays pink after adding sodium hydroxide, while the maternal blood turns yellow-brown because it's an adult hemoglobin, which is more denatured. So this test or app test is useful to detect whether it is the fetal or the maternal blood when the fecal occult blood testing is positive in a baby. What are the limitations of fecal occult blood testing? These are the various methods which we spoke about, but there are some limitations. It is not exactly a complete diagnostic test. It cannot determine where the bleeding has originated from, and it cannot replace any imaging or colonoscopy test. It is only a screening test. The false positive and false negatives and the limitations are quite significant. Therefore, it is only for screening method. So if we look at the clinical aspects also, now that we discussed the laboratory aspects, let's look at the clinical aspects also. There are certain terminologies that you have to be familiar with. One is what is the difference between occult and obscure GI bleeding or gastrointestinal bleeding. So before we focus on to the stool test, it is important to place them in the correct context of the GI bleeding. An occult GI bleed is a bleeding that the patient is not aware of. These patients come with a positive fecal occult blood test. They may present with iron deficiency with no visible blood in the stool. Obscure bleeding, on the other hand, is obvious to the patient and they may have hematemesis melena or hematochezia, but the source is not identified. So these two are different terminologies. And if at all you subject the patient to a colonoscopy or endoscopy, and there is a visible bleed and you are not able to find out the source, then you call it an obscure GI bleeding. It is not the same as occult GI bleeding. The definition are different. So both occult and obscure bleeding can originate virtually from anywhere in the GI tract, usually from the esophagus to colon, but anywhere in the small bowel as well. So it is important that you understand the difference between these two. Then fecal occult blood testing, what is the workup for GI bleeding? Fecal occult blood testing is not a single screening test. It is important to tool it up with other workups for chronic blood loss. In men and in postmenopausal women, iron deficiency should be assumed to be a GI bleeding unless proven otherwise. In reproductive age group, it can be a menstrual bleed in women, but in men and postmenopausal women, GI bleeding has to be assumed to be the cause for iron deficiency. In these groups, other than the nutrition causes, of course, but in these groups, the positive fecal occult blood or IDA warrants an endoscopic evaluation. Typically, the colon is investigated first with a colonoscopy because of high prevalence of colorectal polyps and cancers. If the colon is found to be normal, the next step will be usually an upper GI endoscopy to again rule out any ulcers, erosions, vascular lesions, or a malignancy in the upper GIT. If both upper and lower GIT show nothing, then you have to continue to investigate this again with a small bowel source to be ruled out. So to a small bowel, you can't do an endoscopy colonoscopy. You will have to do a capsule endoscopy or a deep enteroscopy. So this is the next follow-up step that has to be done in case there is nothing in the endoscopy or the colonoscopy. So if fecal occult blood result is positive, it mandates and triggers a mandatory investigation that has to be done, especially in the elderly cases. Another thing is normal fecal blood loss and iron balance has to be understood. Physiologically, all of us lose some amount of blood in the GIT. Like I said already, some amount of mucosa is shed on a daily basis, and that roughly is 0.5 to 1.5 ml of blood per day, or less than 2 milligrams of hemoglobin in stool daily is all right. But if it is more than that, then it has to be investigated, and our commercial product FOBT turns positive, as I already alluded to, greater than 5 to 10 ml per day has to be the loss for it to be detected in the commercial GOAC based testing. So if you look at the iron metabolism point of view, the body normally loses about 1 milligram iron daily and can increase absorption parallelly to counter this to up to 10 milligrams per day in cases of deficiencies. So iron deficiency anemia develops only when there is a chronic unchecked blood loss, more than about 5 to 10 ml of blood per day over weeks or months. So it is very slow. So understanding these numbers, it means that if there is a patient who is otherwise nutritionally sound, he is able to take enough iron nutritionally, and you still have iron deficiency in the patient. It only means that he is losing out blood from the GIT, and your fecal occult blood has to come out to be positive. There are some clinical algorithms for in case you have a patient who is having a positive fecal occult blood test with or without iron deficiency. There are some clinical algorithms that have to be followed for detection. So when the patient is iron deficiency with a positive fecal occult blood test, it is fairly structured stepwise approach that has to be taken. First, the clinician makes sure that the anemia is a true iron deficiency, checking the ferritin, iron studies and excluding other causes. Similarly, repeated fecal occult blood tests may be done to rule out any sporadic false positives, which I already alluded to. The first endoscopic test, especially in men and postmenopausal women, because of colonic neoplasia, is a major concern that has to be done. If colonoscopy reveals a clear bleeding lesion, such as a carcinoma or a large polyp, that largely explains the occult blood. If the colon is absolutely normal, you have looked at the colonoscopy and the colon is absolutely normal, the attention next has to be drawn into the upper GIT. The upper GIT, you have to look for the peptic ulcerations, erosions, esophagitis, portal hypertensions, any hypertensive gastropathy, gastric ectasias, any bleeding lesions, or a malignancy in the stomach. If both ends are normal, upper GIT is normal, lower GIT is normal, then continue to have, and the patient continues to have fecal occult blood test positivity, then you have to then think about angiodysplasias, any excessive usage of NSAIDs, any enteropathy, any small bowel tumors, any Meckel's diverticulum related disorders. So these have to be detected. And capsule endoscopy is looked out for any small bowel lesions. And if this fails and this to detect anything, then this has to be followed up with a deep enteroscopy or an imaging study. Sometimes the patient has no GI lesion found even after this. In these cases, the clinician needs to revisit the diagnosis. This could be an a nutritional iron deficiency. For example, there can be a complete nutritional iron deficiency which is not being detected, or a celiac disease, or some other gynecological blood loss in case there is an iron deficiency which is not curtailed, and or a hematological disorder. So these are the other things that need to be looked at if there is iron deficiency, despite your entire GIT being screened and nothing being found. So, in summary, what all did we speak about? The fecal occult blood test remains a valuable tool for cancer screening. That is what we spoke about, and it requires understanding of the dietary and technical limitations for the testing. We also need to understand how 72 hours prior to testing the patient has to be prepared. What are all the false negatives? What are all the dietary restrictions that you would tell the patient to perform? And always be sure to give the report after 3 different stool samples have been tested. So using the fecal immunoglobulin immunochemical testing is slightly better than the fecal GOAC testing, because fecal immunochemical testing is more specific for human hemoglobin and does not have cross reactions with the animal hemoglobin. For newborn, to understand the difference between whether it is the maternal blood that is followed up or there is a GI bleed in the baby, there is an apt test that is done to help understand the differentiation between a maternal swallowed blood and a neonatal GI bleeding. Always remember that a positive fecal occult blood test warrants a colonoscopy evaluation initially. So these are all the things that I wanted you people to understand. So thank you very much for your patient listening. So this is it from me, and today's topic was fecal occult blood testing. Please like, subscribe my channel, and share it with your peers. Bye bye.